Thank you for joining me on this airway co-management discussion where medicine and orthodontics meet. I've lectured on this topic about 25 years, and it deeply interests me with both the youth and the adult patients who come into our practice. The airway is essential to evaluate as a part of our comprehensive work. We observe that the patients often have airway compromises or conditions that obstruct the airway, and this influences the upper jaw width, the lower jaw posture, and the ability or inability to use the nasal complex for natural breathing. In some of the cone beam 3D images we now take and the software which delivers and renders these images, we can see the obstructive conditions from the adenoids and the tonsillar regions, and then of course up into the sinus regions as well. And we can do harm by doing nothing. So it's very important to analyze and recognize these conditions and then refer to our colleagues to co-manage these patients and do the best for them. The patients often have class 2 skeletal conditions. The upper jaw might be normal, the upper jaw might be prominent, the upper teeth might be prominent from the condition. More often, the lower jaw is deficient skeletally, and with this deficiency, it encroaches upon the nasopharyngeal airway. So we have compromised airways with skeletal jaw mismatches. If we can't breathe, we get poor sleep, and we have other dental conditions. It's very common to see bruxism and grinding of the teeth and altered sleep patterns for patients, and so the dentist may recognize the wearing of teeth, but actually the more important thing is the etiology that relates to the airway and the inability for natural and normal breathing for this patient, and that alters sleep patterns, and then it alters the movement of the mandibular complex and the clenching and grinding conditions that often accompany these problems. So they can be pretty aggressive with the grinding, and the teeth can go through a lot of wear, and sometimes rather severely so. So this gentleman came in seeking help for his dental conditions, but really his airway needed attention first. The pediatric airway is very important with these patients. We know today that overweight children are about 30% and growing, 30% more in the population today compared to 5% in 1980. So in 30-some years, it's changed dramatically. With obesity and sleep apnea, for every hour of sleep lost, we have about an 80% increase in obesity risk. Kids have these problems too, and of course they have structural conditions with the high palates in about half the cases. So the maxillary transverse width is deficient, and then there's a class 2 relationship of the jaws and the teeth. So these kids have a lot of structural compromises and compensations for these conditions. And of course there's also the increased risk of ADHD. This also influences brain maturation and child behavior. So the obesity for youth has gone from 5% in 1980 to over 30% today.
HIJKLMNOPQRSTUV 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
You notice the hypernasality, the narrow arches, the tongue cannot posture properly, and speech is made very difficult with a lot of compensations. So obstructive sleep apnea in children has a peak incidence in the very young already. And there's no difference between boys and girls. Obese children have 4 to 5 times more moderate to severe OSA, and ethnicity plays a role in this. So we've got to recognize this in the young kids and help them. So the nasopharyngeal upper airway is constricted, the arches are narrow, the teeth are crowded, many times they grind their teeth, and these children really struggle with getting good rest and then performing well in the classroom and just being able to be having a normal childhood. So whoever sees them first, whether it's a medical colleague, the dental colleague, or others, even many times the parents will notice that these kids can't breathe normally, they often snore, they struggle with rest, and so they need to be helped. Obstructive airway conditions include narrowness of the jaws and crowded teeth, and that relates directly to mouth breathing conditions. We want to observe carefully and thoroughly the problems for these kids, so when they come in for examinations, we'll see the jaw and bite problems, but also we'll want to let the parents become aware, if they aren't already, of some of these conditions and how it relates to the airway. Of course, then we'll turn to our ENT colleagues to give us help and to help that patient be having the best health circumstances. So the transverse jaw and bite interrelationships relate to nasopharyngeal function and airway competence. So in this case, you notice that there are findings in the nasal airway and certainly in the pharyngeal airway with the excessive tonsils and adenoid regions and the narrow dental arch and the narrow skeletal structure. So we need to help these patients with clearing the airway, widening the upper jaw, and then bringing the front teeth together so they can speak and swallow more properly. So when we look at these cone beam 3D images, it's really virtual laryngoscopy. It's the best way to analyze and assess the airway. So we use cone beam, CBCT, and then various 3D software programs. We have installed the Dolphin, the 3D Anatomage, access to Invivo 3D, Compass 3D, and Motion View 3D. So we've invested in this. We're committed to it. We want to rely on these programs to help us with renderings to bring forth the findings on these patients. And that's becoming the standard of care. In fact, a few years ago in a California journal, it was already published by an attorney and by a maxillofacial radiologist that difficult orthodontic cases, and these airway patients are in those groups, really need 3D imaging to be part of the patient analysis. This example shows the dental facial orthopedics we can accomplish, the widening of the jaws and the reshaping of the jaws, which increases the space for the tongue volume, so the tongue can posture up in the dental arches and up in place rather than being in a narrow arch, which encroaches the tongue back upon the airway. So the arch shape change is very important to accomplish. And this is done with facial orthopedics. So the sutural growth is modified and the arch becomes wider and normalized, and that makes room for teeth. And of course the smile and the bite gets better, but really more importantly, the airway is helped. And we have to overcorrect about 20 to 30% in that width to anticipate what growth will occur from the moment of treatment until maturity. There's various appliances we've innovated, and the idea is to have them widen the arches but also gain more room for the teeth to fit, because generally there are crowded arches and we want to try to create enough room to normalize the arch and then be able to fit the teeth in properly as a part of the orthodontic treatment. And one of the huge conclusions from the research is that with the improvement by expansion appliances, these are structural or sutural expanders, but with these there's much more computational fluid dynamics. The airway just simply works better when the upper jaw is widened. And then once we do have that width, we can try to restore nasal breathing, and we can use tongue shields and different oral appliances as retainers, but also it obligates the patient to use the nose box to do nasal breathing and bring the lips together for good lip seal, so we can help that patient as time goes to retrain. In more severe cases like Creson's, you can see the severe structural narrowing and the early fusion of certain sutures, so we can't widen sufficiently, so then we have to turn to the surgeon to give us help. The maxillofacial surgeon can assist with freeing up different osteotomy sites, and then we can expand and optimize the condition. More commonly, we do it with natural growth and sutural expansion appliances. And then aesthetics is certainly important. We want to protect the smile arc and get the teeth in the right place relative to the lips. So many times these kids have the tongue thrusting forward and the teeth get flared out. So the teeth need to become aligned, but we need to do so recognizing what the airway conditions are and what the normal placement of the teeth should be in the facial structures so they can have a nice aesthetic smile. So there's some widening steps that happen, some braces steps, some Invisalign steps that are done today, and this makes a big difference in the outcome for the patient, the beauty of the smile. So it becomes important to question the patient with a simple Epworth questionnaire to have them indicate what they are experiencing and what the sleepiness is for them. And if we get up around 10 or more in total points on the scale, then it's important that we seek other medical colleagues to assist them for the problems. You can see that the arches have been widened, the teeth have been made straight, but the colorized region of the pharyngeal airway is that the black region is the most incompetent, the red is somewhat of a problem, and then the blue, green, and other colors indicate that there's normalized airflow. So where it's black and red, there's a problem. So here the tongue size is excessive and falls back. So many of these patients benefit from having some kind of removable postural appliance they wear when sleeping to keep the tongue volume away from the airway and to help them with snoring conditions and apnea conditions. So there are a number of designs, but we want to titrate where the jaw postures so that it's sufficiently forward and sufficiently open to help the patient based on their airway compromise. So we need some analysis, some volumetrics to understand what's the problem in the airway, to then understand what the design and placement of the appliance should be, and then where the jaw posture, lower jaw posture, should be. So this gentleman has a large neck size, so that's another indicator. When patients have 18 or more inches of neck size, and that's an indicator that we might start suspecting there could be a condition. So the scan reveals the red compromised region, so the tongue is encroaching on the airway, and with a postural appliance it's been improved. So you can see it's all yellow and open at that point. So when they have snoring and apnea conditions, we start suspecting that there might be a class 2 mandible or a tongue volume problem. The neck size might be excessive. Certainly the sleepiness scale and score might be high. And certainly if the teeth are crooked, we're concerned about that, but much more importantly is the airway and the other sleep conditions. Nobody died from crooked teeth, but if the person falls asleep at the wheel, there can be a severe problem, obviously. Sleep apnea and snoring on the growing patient actually is able to reshape and modify the jaw morphology to the point that the elevator muscles of the mandible, at the point where the depressor muscles around the suprahyoid regions work in opposite directions, and that's at the antegonial region of the mandible, and it actually creates a bending of the mandible and a change in morphology, as you can see in this example. So this is during the growing years, and it clues us how long the problem has been evident. You can see the airway closes off, so rather than being a large rectangular region, the whole region becomes compromised, and we have to identify why and where in the airway with these scans. So for this patient, he's got a class 2 mandible, the tongue volume is back, he's got forward head posture, so there's craniocervical problems for this patient as well. Another example of the airway encroachment on this patient, so we actually have a radiologist read this and help us with what is observed so we can be very thorough for that patient. And once we posture the jaw into its proper place, the more neutral posture, then the dynamics in the airflow are improved, the volumetrics improve, and you can see the numbers for this patient and how much improved it is. The cross-sectional area for high-risk OSA patients really is able to be measured and is different based on jaw posture and encroachment. So there's a lot of importance of teaming up with what we can do with appliances and analysis and 3D imaging, along with what the sleep doctors do and what the other professionals do, the other medical colleagues do to help these patients. But shape of airway and cross-sectional volume measurements are really important today. So before, you can see on the left the red area where the mandible is postured back and the tongue is in the airway, versus on the right where it's postured forward. And then the analytics showing that we have 90 square millimeters of volume before, and we're up to 165, so it makes quite a difference. Well, all these things put together helps us to normalize the structural components for the patient, the bite and the jaws and all that, but much more importantly, the airway and the quality of life for these people. So I hope some of this information has been useful in this 3D airway discussion. Thank you very much.